Okay, so good afternoon, members. We do have a quorum, and I want to call now the concurrent meeting of the Health and Justice Committee to order. And I welcome all members who are present here in the Senate chamber, including Mervyn Story, Chair of the Justice Committee, and those participating by video conferencing. Can I remind all members about the protocols regarding the use of electronic devices? Members, I have an apology from Jerry Carroll, MLA, for today's meeting. And I also have an apology from Emma Rogan, who has delegated her vote to Sinead Ennis for the concurrent meeting. And I believe that Carol Killen may need to leave the meeting before it concludes and has delegated her vote to me in that situation. Yeah, Clerk, can I check with the both clerks?
Christine, is there another one or no? It's okay.
So that's all the apologies we have at present, members, so thank you. Members, moving on then to item 2, which is our briefing on the review of services for vulnerable persons detained here in prisons in the North. We will be briefed today by officials on the recommendations of the RQIA Report on the review of services for vulnerable persons detained in prisons. A clerk's memo outlining the procedures and providing further information on the RQIA Report and recommendations is included in your pack at page 2. Also included in the pack is a copy of the RQIA report, which was published in October 2021. A written update from the Minister of Health is included at page 83 of the pack, and a copy of correspondence from the Department of Justice to the Committee for Justice is at page 93 of your pack. So I will, members, in the first instance, I'll make a few questions myself, and then from the Deputy Chairperson of this meeting, which is Mervyn today. Members should indicate in the usual way if they wish to ask a question, please. So I'm going to now invite and welcome the following officials, and I will go through the list of officials, and then I'll return to Robbie to open up the opening statement. So we're joined now by Robbie Davis, who's General Healthcare Policy Director within the Department of Health, Roisin Coulter, who's Chief Executive of the South Eastern Health and Social Care Trust, Margaret O'Kane, Director of Adult Services within Prison Healthcare in the South Eastern Trust, Rachel Gibbs, who's Assistant Director of Prison Healthcare in the South Eastern, Paul Turley, Assistant Director of Commissioning within the HSCB, the Health and Social Care Board, Siobhan Donald, Assistant Director of Nursing in the PHA, Ronnie Armour, Director General in the Prison Service, David Kennedy, Director of Prisons, and Julie Anderson, Head of Prisoner Wellbeing within the Prison Service. So that's a large and a very, I'm sure, expert panel, and we will try to work our way through the question and answer session. If members of the panel can indicate who is going to lead principally on an answer from members, that would be useful. And then only if there's additional information, could other members contribute if they wish to add anything additional to the principal answer. So I will go first of all back to yourself, Robbie, to ask if you could make your opening statement, and then I will go to Ronnie Armour to make a brief statement on behalf of Justice. So first of all, Robbie, on behalf of the health bodies, can you hear us okay there, Robbie?
I can hear you. Thank you, Chair.
Yeah, and we're hearing you, Robbie, so Gorma Agat, and please go ahead. Thank you.
Thank you. Good afternoon, and thank you, Chair, for the opportunity to provide an update on the RQIA report into services for vulnerable persons detained in Northern Ireland prisons. I thought it would be useful to start with an overview of where the responsibilities lie between the different organisations involved in healthcare in prison. The Department of Health has joint responsibility, along with the Department of Justice, for the strategy Improving Health within Criminal Justice. The Health and Criminal Justice Implementation Group, which consists of members from a wide range of organisations in both health and justice, has the role to ensure the actions arising from the strategy are taken forward and provides a platform to discuss any matters arising. It also oversees the implementation of recommendations arising from audit reports, inspections and review reports, including this RQIA report. The Health and Social Care Board and the Public Health Agency have responsibility for the commissioning of healthcare services across the 3 prison sites. They have an established planning and commissioning team for improving health within criminal justice. The South Eastern Trust has been commissioned since 2008 to provide healthcare to all people in prison in Northern Ireland, and their team includes a wide range of healthcare professions. Moving on to the report itself. The RQIA review was jointly commissioned by the Health and Justice Departments, focusing on the care provided to people in prison with mental ill health who were at risk of self-harm or suicide. The review was undertaken from December 2020 to February 2021, during which time the Prison Service and the South Eastern Trust faced considerable challenges posed by the COVID-19 pandemic. This also meant the review was conducted virtually and that the expert review team did not have the opportunity to access the prison sites at that time. RQIA published their report during October 2021, and the findings are very much welcomed by the Department of Health. The report put forward 16 recommendations which RQIA believe, if fully implemented, would lead to better outcomes for vulnerable people in custody. The expert review team found that both the Prison Service and the South Eastern Trust had made great efforts and commendable progress since previous reports, in particular in relation to the supporting people at risk process and improvements in partnership working and in governance. They also commented on the capability and commitment of staff across both the Prison Service and within healthcare and prison team, recognising the compassion and dedication of staff to make things better for people in prison. As mentioned earlier, the report puts forward 16 recommendations that were prioritised in relation to the timescales in which they should be implemented. I'd like to reiterate this point, highlighting that the recommendations have been prioritised into 3 categories based upon the timing in which RQA believes that they should be implemented, which may be different from the importance of each recommendation. This may differ from how recommendations have been prioritised in other reports. The HSC Board and the PHA have lead responsibility for 14 of the 16 recommendations. DOH has lead responsibility for 1 and the Prison Service have lead responsibility for the other. Following the publication of the RQIA report in October, a working group was convened jointly by the HSC Board and the PHA to consider how best to deliver on the recommendations. The recommendations have been grouped into common themes and task and finish groups have been established to take them forward. There are 6 themes as follows: benchmarking, capacity and capabilities, mental health assessment, data collection, future commissioning, and transition to community. Preliminary meetings took place during January for each of the 6 themes. The groups have a wide range of members from organisations including the Royal College of Psychiatrists, the Prison Service and the Probation Board for Northern Ireland. The importance of having user involvement is also recognised within this process, and the South Eastern Trust are currently engaging with organisations and individuals to contribute accordingly. Given the report was published last October, all recommendations are still under active consideration. Currently, there's good momentum in each group taking forward the required work. The Department of Health, HSC Board, PHA and South Eastern Trust are very much committed to driving this work forward and welcome the opportunity to engage with a wide range of stakeholders, wider than has previously been engaged in this work area previously. The work to consider the implementation of these recommendations will very much be a collaborative effort across a wide range of organisations. It's also important to highlight that this work commenced during the period at which the Omicron variant started to surge in Northern Ireland, putting additional pressures on all frontline services and health organisations. In this period, priority had to be given to the continuation of frontline services, including the vaccination rollout scheme. We're very pleased to inform both committees that the response to COVID-19 across the prisons in Northern Ireland has been very positive. South Eastern Trust Healthcare and Prison, in collaboration with partner organisations, took very swift action in relation to COVID in early 2020, adopting a whole prison approach. The positive outcomes of this have been very well documented. In fact, we're not aware of any other jurisdiction who have had fewer outbreaks, no hospitalisations nor deaths due to the COVID pandemic in the prison population. It's also important to note that the timing of the report being published, coinciding with the Omicron surge, has created an additional challenge to implement the recommendations within the timeframes put forward in the report. Even though good progress has been made, unfortunately, it's unlikely that the first priority 1 recommendations will be implemented within the first 6 months of publication of the report. Discussions around more appropriate timeframes with RQIA will be taken forward. And we are, of course, happy to provide the committee with a more detailed update on implementation of the recommendations as progress goes on. Thank you, Chair.
Okay, thank you, Robbie. And then just before I go to Ronnie, if I could ask members to use the raise hand function on your screen, if possible, just given the amount of panel members and committee members we have, it may be difficult to spot people raising the hand in any other way. So if members want to do that at any point, I'll then take the questions after I've went to Mervyn. I'll take the questions in the order in which they're raised on screen. So thank you, and I will just go then to Ronnie, and first of all check, Ronnie, that you can hear us okay?
Yes, Chair, we can hear you fine, thank you.
Yeah, and we're hearing you, Ronnie, as well. So if you want to go ahead with your briefing to the meeting, go ahead, please. Thank you.
Okay, Mr. Chairman, I welcome the opportunity to discuss this important report with the joint committees today. And at the outset, I want to thank the RQIA for undertaking it, and Professor O'Neill, our mental health champion, for the support and the help that she has given the prison service over the past few years. The opening words of the executive summary set, I believe, the context for this report and put beyond doubt why it is an important one and why its recommendations must be implemented in full. The author writes that Northern Ireland has a 25% higher prevalence of mental ill health than the rest of the United Kingdom, and this higher level is reflected very much so within the prison population. The fact is underpinned by statistics provided in the report, which indicate that 36% of prisoners reported that they were in contact with community mental health services at the time of their committal to prison. 58% had a history of substance or drug misuse, and 44% had a history of self-harm. If I can update the committee and update those figures for the committee this afternoon, in our prisons today we have approximately 495 individuals with a history of mental health issues. We have 831 approximate individuals with a history of substance misuse and 862 with a history of self-harm. Chairman, that is the scale of the challenge that prison officers, nurses and other healthcare colleagues who work alongside them face on a daily basis within our prisons. It is a concentration of people who are unwell and individuals with a myriad of other complex and challenging needs and behaviours that sets the work we are doing apart from all others. I welcome the fact that this report recognises the compassion and dedication of the very capable and committed prison officers and healthcare staff working in our prisons, and I'm grateful for the acknowledgement of the results delivered by our new Supporting People at Risk Evolution approach introduced by Julie Anderson, who's with me here today. That approach was developed by Julie and implemented at no additional cost. This person-centred approach has, according to the report, delivered a 29% reduction in the self-harm rates amongst our female population and a 67% reduction in the rate amongst our young men. While these are impressive results, there is no room for complacency, and we must strive to do even better. While it is important that we recognise the scale of the challenges we face and the commitment of our staff in facing those challenges, it is also right, and this report is very clear in doing so, that we acknowledge the constraints within which we have to work and operate. Healthcare in our prisons is significantly underfunded in comparison to other regions of the United Kingdom. Indeed, this report estimates that the shortfall is approximately £4 million per annum. The role of the prison service is to hold securely those placed in our care by the courts and to work with them to reduce the likelihood of them reoffending on release. In essence, to ensure that we have fewer victims in our society. To do that, we must first stabilise those individuals, and at the core of that process is the requirement to address both their primary care and mental health needs. This report is clear that we don't currently have the adequate capacity to do so, but if fully implemented, the 16 recommendations made by RQIA will deliver the necessary improvements. 2 of those recommendations have been directed to the prison service, and I want to assure both committees that we will work with our healthcare partners to ensure their delivery as quickly as possible. Whilst work goes on in our prisons is out of sight, and seldom a priority for society. It is in all our interest to ensure that those in the care of the prison service enjoy the same standard of health care that are available in the community. Both this report and the recently published Criminal Justice Inspection review of the operation of care and supervision units are clear that those in our care who are vulnerable deserve better, and central to achieving that outcome is the full implementation of this report. Thank you, Mr. Chairman.
Okay, thank you, Ronnie. And I'll be going back to yourself first of all, Ronnie, in relation to, and I would be seriously concerned at the figures you're citing there. That's quite shocking. I know you've said over 500, I think, with mental health issues in the prison population. Could you also just reiterate what the figure was in relation to self-harm and addiction?
Chairman, we calculate these figures on committal people coming into the service. 495 individuals approximately in our care today have a history of mental health issues. 831 individuals have a history of substance misuse, and approximately 862 have a history of self-harm. I agree with you, those figures are quite disturbing, and I wanted to provide them today because I think they help the committees understand the importance of this report and the importance of ensuring that we do everything we can to make sure that these individuals, many of whom are very vulnerable, get the help and the support that they need. Thank you.
And I presume there may be some element of comorbidities in that sense, of people having more than one problem. But in total, how many detained persons would you consider, out of the 1,500, I believe, overall population in that cohort, how many of those would be deemed vulnerable?
Mr. Chairman, we have today 1,573 in terms of the numbers that we would consider vulnerable. Julie, do you want to?
Well, I suppose anybody who is within the prison community could be considered to be vulnerable for a number of different reasons. In the context of this report, vulnerability was looked at in the context of people who have mental health issues and people who are at risk of suicide or self-harm. So based on our figures today, 31% of the prison population has some form of mental health issue. 51% of our prison population have a history of addictions and substance use, misuse. And we have 54% of our prison population have a history of self-harm. So that sets the broad context of what we're looking at. So you're looking basically for addictions and self-harm, over 50% of our population are affected.
Okay, and that's a hugely worrying, and I'm also aware from other discussions we have done with, even for example, speech and language therapists, the amount of vulnerability that was within that population, even in terms at times of communication issues, is a real issue. So I'm going to go then for my second one back to yourself, Robbie, in relation to, and you had touched, but are you saying there are 3 recommendations there within the report, 4, 19 and 14, that have been given priority 1? That was that they were to be completed within 6 months of publication, which would be the start of April. So are you telling us that none of those 3 will be completed by the 1st of April? And if that's the case, when do you anticipate those will be delivered upon?
Chair, essentially, in short, yes, I think that given the unique factors and circumstances that coincided with the publication of the report, that there will be some degree of delay. I think it's probably useful at this point to see if colleagues in PHA or the board would like to come in and maybe give a more detailed response to your question.
Thank you.
I would be happy to come in at this point and just comment on the 3 priority 1 recommendations, if you're content for me to do that.
Yes, please, Paul, yeah.
Okay, just in terms of the process that the board and the Public Health Agency have put in place, once the publication was launched back in October, we had the opportunity to meet as a planning team at the board. We have a healthcare and criminal justice planning team. We met to review the recommendations. That review meeting also involved our department colleagues. We then picked that up with our colleagues in the South Eastern Trust and put in place a task and finish group to take forward the recommendations, which we coalesced into a number of themes, and Robbie outlined some of those key themes in his introduction. Obviously, our priority was in relation to the Priority 1 recommendations, which covered benchmarking, issues around substance abuse and opium substitution therapy, and then reference also has been made to the current support unit. So those were very much in terms of our focus. The relevant task and finish groups have met, some of them on a number of occasions, so we have been able to come to a position in relation to those Priority 1 recommendations. Again, I would reflect back, colleagues, to the issues that were raised again in the introduction around capacity. We were very much impacted in terms of the terms of reference groups that we have and the membership of those by the Omicron variant surge that we had running through November, December and January, and still with us at this point. But there was a momentum around those task and finish groups. So specifically in relation to the benchmarking task, we have worked through some contacts that we have across the 5 Nations group of prison healthcare. We sought information from them about benchmarking that we could link into in GB and the Republic of Ireland. Unfortunately, there isn't any benchmarking activities on a national basis going forward at the moment that we can work into. So that was a bit of a challenge for us. We then approached an organisation called NHS Benchmarking, which specialise in benchmarking services, and had a conversation with them. And unfortunately, it would take time to put that in place. So we did then have an opportunity to speak to a member of the expert review panel who actually led on the benchmarking issue. He has been able to link us up with colleagues in the northeast of England who we will contact or are contacting with a view to understanding how they work through the benchmarking of their services at that regional level. And we'll try and work through with them in relation to a benchmarking exercise now for Northern Ireland. Sure, that will take us a bit of time to operationalise that, but I'll maybe come back to a conversation that we've had with the RQIA very recently just about the timelines. In relation to the opium substitution therapy and substance abuse, we were able to work through that issue quite quickly by commissioning some outside expertise to come into Northern Ireland to review that. So Dr. Nat Wright, who is a GP with a particular interest in criminal justice and substance abuse in prisons, and is also a professor in the University of Leeds, is coming over to Northern Ireland to undertake a rapid review of opium substitution services both in prison and outside prison. His report should be with us probably by the middle of April. And on the basis of that report, we should be able to make some judgments around where we go to in terms of commissioning requirements following out the other side of that. So we're very positive that we will be able to move forward on that one fairly quickly. In terms of the CSU issue, I know there's been ongoing discussions between the Northern Ireland Prison Service and the Trust, following obviously the publication recently of the review in terms of the CSUs and the operational workings of those. So I think some further conversations to be had around those. I did mention just a few minutes ago about conversations with the RQIA in regard to the timelines in the context of the pandemic. We do have a formal meeting with the RQIA coming up on the 7th of March, which we're going to table our updates in relation to where we've got to so far. And I think the RQIA understand the conditions that we've been working in over the last number of months vis-a-vis the pandemic and the availability of key staff to take these forward. So I think they will be seeking from us our view as to when we can deliver in terms of these recommendations and the rationale for that. And certainly we will be keen to provide them with that detail whenever we meet with them.
Okay, thank you, Paul. And I do acknowledge that there have been those difficulties. However, it must be said, these are an extremely vulnerable group of citizens, and I suppose I would just encourage that all haste is made and all focus is placed on getting those important recommendations completed. My final one then was, and it may be Robbie, I think, more so than, is how are you going to monitor progress in delivering better outcomes for vulnerable prisoners? And also, significantly, what further engagement will there be an ongoing engagement with detained persons and indeed with their family members, and thinking children here, and engaging with all of those who are impacted as a result of someone being imprisoned?
Thank you, Chair. And on the first point, we have governance arrangements in place, as I had alluded to in my introductory comments, and through those processes we will be monitoring how the task and finish groups are progressing their work. On your second point, it may be useful, Chair, if you're in agreement, to take the view of the Trust on that particular angle.
Yep, thank you. So could a Trust member please identify themselves to that?
Yes, it's Rachel Gibbs here. Can you hear me okay?
Yes, we're hearing you there. Yeah, we're hearing you. Thank you.
Yeah, so in relation to service user involvement, there's been considerable work done in the last number of years alongside the prison service and with health colleagues in introducing an engagement model within the prison setting. So we have an engagement lead for each site whose sole responsibility is to engage with the men and women who live in prison to get their views and to ensure that they are instrumental in the co-production of any services being developed in the future. We have a number of innovative programmes with the young men. There's banter and buns, there's different sort of more light-hearted, if you like, sessions that aren't overly formalised or intimidating for the people who live in prison, but give them an opportunity to share their ideas or their experiences of how it is to be in prison, or what would help in terms of moving them forward and supporting them on release. Some of the most significant issues around transition, and we know that, and so we are working closely with our partner agencies in the community as well as the trusts in the community. We also have links with NIACRO, who work with families in the community, so that we can ensure safe introduction of user involvement there. We have to be cautious. Sometimes families can also be victims, as you know, and so we have to be careful how we engage with the family groups. But we have the same people who work in terms of the engagement in the prison settings lead on some of the projects in the community to ensure we link with those families.
Thank you. Okay, so I'm going to go then to our Deputy Chair, Mervyn Story. Go ahead, Mervyn, please.
Thank you, Chair, and can I just place on record our appreciation in the Justice Committee to all those who were engaged in the commissioning and the delivery of the report, and also for the work that has been done to date, both by our prison officers, staff, and also our healthcare professionals in our prisons in Northern Ireland. I want to return, Robbie, to the issue in regards to recommendation 14, and I take the point that has been made, and I understand the context in terms of the challenge over the last number of months because of COVID and other issues. But recommendation 14 was very clear that the commissioners in both the HSCB and the Trust should develop an algorithm to assess the suitability of the individuals placed in CSUs. Given that we have now another report from the RQIA, from Sir Jenny, in relation to the units, is there now not a need, not for conversations, but actually for an urgent implementation of that recommendation, so that there is a process whereby we clearly identify the needs of individuals, and what assessment from a mental health perspective is currently in place for those vulnerable prisoners, because it is, I think, on the basis of the figures that the Director General has given to us, it is alarming. And of course, the Director General knows that I've raised this issue with him. I'm also very concerned about the number of remand prisoners that we have, and that's another category, I have no doubt, in which there are particular mental health challenges.
Thank you for your question, and indeed we do in the department and other bodies here fully appreciate the challenges and the issues around the CSU. In regard to your specific questions, I think it's possibly best addressed firstly by Paul Turley, and the Trust may also wish to comment.
Thank
you. Chair, as I mentioned earlier, the issue is a priority one recommendation, and one obviously that we need to move forward on at pace. There has been those conversations, and you do reference the recently published report as well from CGNI. So I think we're looking for clarification around that point, and those conversations with the Northern Ireland Prison Service and the Trust in relation to the specific points made in the RQIA recommendation need to be clarified. So once we have that clarification, then I think we can move forward on that particular issue. But I'll maybe hand over to Trust colleagues who might want to pick that up in a bit more detail.
Since the involvement of RQIA at the original, at this for the first report and then the subsequent review of the CSUs, all people who come into prison in Northern Ireland are seen by a mental health practitioner. That is new in the last year. They would have been seen as a referral from the primary care assessment initially, but now we have introduced a new model where everyone is seen by a mental health practitioner, so we can ensure accurate and early and timely mental health assessment. And that we work within the NICE guidelines. There's a recommendation that everybody should be seen within 7 days of committal, and we invariably we do that within 2 or 3 days, but we're well within the NICE guideline recommendation. Everyone is seen anyway on the first night by a healthcare practitioner or a health professional, and so there is always the opportunity to see somebody on an urgent basis if required, and that is on committal. I think work was done a number of years ago in relation to the CSU environment, where all people who come into that environment are assessed by a healthcare professional. That assessment was a more general assessment, and the recommendation from both reviews really focused the need to more explicitly describe how we do the mental health element of that assessment. And we have now implemented that already, because as you have acknowledged, it's extremely important, and we're working very closely with the Northern Ireland Prison Service, who inform us very promptly through the radio. So there is an actually immediate, as soon as somebody goes into the CSU environment, we are immediately informed by our colleagues, who also can provide us with information about whether, it's extremely urgent that we attend. So I think the recommendation says within 2 hours. For some people, that's far too long to wait, and for other people, it doesn't need to be done even within that time. So we work as responsibly as possible, and we have a very responsive sort of urgent on sites, on all 3 sites 24/7, and I think that is work that we're very proud of, and it has really improved our assessment of those individuals. I think that primarily people with who are experiencing mental health difficulties in the prison setting are not housed in the CSUs unless their behaviour is extreme and their presentation is extremely challenging, and that they're placed there for safety, and the South Eastern Trust provide a very close service to those individuals.
And I suppose just 2 other brief comments, and thank you for that. One is in relation to what challenges does the organisations, whether it's the HSEB or the Trust or indeed the Northern Ireland Prison Service, face in regards to the whole area of data protection, of ensuring, and I know that our colleague from the Trust made reference to the guidelines that are there, that are in place, but are there any other challenges that makes it more difficult? For example, access to GP records, access to the history of the particular individual, given the fact that some of these people, some of the prison population are repeat offenders, and obviously would have been known previously to the health practitioners and also the prison staff. That's one issue. The other one is really to Ronnie, and it also applies to our colleagues in health as well, but also to Ronnie. One of the issues that was raised in the report was the constraints of existing resources, and given all the talk, and it sadly is just a lot of talk about the budget, it seems as though there will be a massive pressure on the budget, particularly for the prison service. And how concerned are you, Ronnie, that this will have an impact on how decisions can be made which will directly be of benefit or to the disadvantage of the current prison population?
Thank you, Deputy Chairman. But there's a number of points maybe if I can touch on in answering your question. I do think recommendation 14 is extremely important, and I think the sooner we can implement this recommendation, the better. We, for our part, are notifying SET within 2 hours of anyone going into the CSU to give them the opportunity to do an immediate assessment. But I think implementing this recommendation would take us a considerable further distance in terms of improving the service that we're providing. The question you asked me in relation to the budget, I mean, I'm obviously very concerned about that, and as you know, I gave a report to the Justice Committee a couple of weeks ago that highlighted the concerns. Healthcare is, of course, funded by our colleagues on the health side and in the South Eastern Trust. But if the prison service budget is reduced, as we anticipate it might be, that will mean fewer prison officers on the landings. That will mean less engagement. And that will mean that we are unable to do some of the really good work that we're doing around rehabilitation and around getting alongside many of these vulnerable individuals who, as Rachel said, don't find their way into CSU, but are being dealt with by prison officers on a day-and-daily basis on landings in each of our prisons. So I am quite concerned about the budget. And we await to see what the final outcome of that will be, but certainly it's looking very difficult for us in the next financial year.
Okay, thank you.
Thank you, John.
Thank you. So with the indulgence of Colin and Paula, I'll maybe go to Carol, because Carol has indicated she does need to leave the meeting early. So we'll go to Carol and then we'll go back to Colin and Paula. Thank you.
Thank you, Chair, and thank you other members just for facilitating me, and thank you to the panel. I think since 2007, but certainly since the devolution of justice, there's been a series of reports, and I've no doubt the intentions of all staff that are here and are not here are just trying to have better outcomes for people. But I wonder, could you talk about the need to have what is known as dual diagnosis, particularly for people who are in and out of custody? And to be honest, it's not your call, it's because I've got mental health problems, so the levels of reoffending and what help they'll get. And then my last question is this, do you all know what budgets you have, given the fact that we don't have a budget because the DUP left the executive? Do you know what budgets you have for the next 12 weeks, and will it impact on service delivery?
Okay, so I think that's for yourself in the first instance.
That's an opportunity.
Ronnie.
Well, sir, the issue of the budget, as I said to Mr. Story, is a concern for us. We know what budget we have until the end of the financial year. We haven't been allocated a budget beyond that. We were working on the basis of the draft budget that had been put out for consultation, and that would have seen a 2% reduction in terms of the prison service budget on top of the pressures we currently have. But we're currently unaware of what the situation will be or what the final budget will be. In terms of the dual diagnosis point, I mean, I think Rachel is probably better in a position to answer that than I would be, Chair, if that's okay to pass it across.
Yep, certainly. And Rachel, please, could you pick up on the dual diagnosis?
Chair, Margaret's going to come in on that.
Okay.
Chair, maybe if I could come in on that. I suppose the first thing to say is the Trust provides healthcare services in prison as directed through the commissioning process, and so the services we're commissioned to provide are the ones that we prioritise. But I would have to say there is a growing recognition of how beneficial it would be for the prison population for the issue of dual diagnosis to have increased resources to see what we could do with the population. And I think that the point is very well made. It's a very transient population. A significant number of the people who form the prison population would actually be in prison for less than a week, and the opportunity to work with them to affect any real change in their lives is very compromised because of that. And I think actually, if we think about the transition process and about how we help people cope with their release back into the community, there's a fabulous opportunity there to link people who have suffered health inequality because of their life experience, help them to see that it's beneficial to link with health-related opportunities in the community. So, for example, we can make referrals to services in the community, but people may choose not to engage, and then there's a missed opportunity. So I think there are a lot of things that we can do, and we certainly would be very keen to do it. But in terms of our psychiatrists, for example, need a period of time to work with someone, to assess someone, as do our psychologists, in order to make diagnosis. So the issue of dual diagnosis is very difficult. I suppose one of the things that we consider, and it goes back to a point made earlier, is we do have access to people's health records, and there's a lot of good joined up working between community healthcare professionals and prison healthcare staff, that important information, particularly if someone already has a diagnosis, that we would be informed of that, and that our support would be tailored in a person-centred way to help people. But I suppose what concerns us most is the revolving door, as you say, where people are in and out, and where do you stop that so that people can get the help they need? And sometimes the help starts with the diagnosis, but it's very difficult. And if we had additional resources, it would be absolutely wonderful to be able to do some of that work ourselves.
Okay.
In terms of the budget then, well, the budget we're aware of is that will take us to the end of the current financial year. But obviously we are in discussions with our commissioners, both the board and the department, around the direction of travel coming into the new financial year then.
Okay, thank you, Margaret. I'm going back then in order to Colin McGrath. Go ahead, Colin, please.
Thank you very much, Chairman, and thank you to the panel. I suppose just with COVID working, my head's buzzing. There's about 4 or 5 organisations in different places. It's such a big meeting, but it's good to see everybody to be able to discuss the issues that are very important. There was just 2 elements of the report that I wanted to maybe get some feedback on. One was on the fact that the RQIA had pointed out that there wasn't a strong system in place for capturing data, and certainly something from the Health Committee perspective that we often have discussed with various organisations is that the capture of data is critically important to be able to let you know what it is that you're dealing with and what it is that you need to direct your resources to. So given that the RQIA has highlighted that there is a bit of a deficiency in that, are there plans in place to be able to try and address that?
So I'll go maybe to yourself, Robbie.
Chair, I think this may be one that the board will want to comment on initially.
Okay. So
yes, Chair, I can pick that up and trust colleagues will want to comment on it as well. And I think absolutely, in terms of Mr McGrath's point, the data collection has been a challenge for us in relation to the prison health agenda. I think part of that is due to the system that's currently in place, which is a primary care clinical collection system, which is requiring replacement. We had been talking to the Trust for some time about the opportunity to do that. But we're very conscious that we have the new Encompass platform coming along very shortly in relation to the upgrading of information systems within health and social care. I'm sure committee members on the health side will be very much aware of the Encompass platform and the potential that has into the future in terms of the information that we will be able to get out of many different types of systems that are currently in place. So we're very optimistic about that, and we're also optimistic about the fact that the South Eastern Trust will be leading the implementation of Encompass across Northern Ireland, and we would like to see the opportunities for prison healthcare systems to build in and inform that.
Thank you, Paul, and I'll go across then to the Trust representatives. Go ahead, please.
Yes, I think as we take on sort of the quality improvement agenda, data becomes essential for us as we move forward in health improvement. We are working very closely with the Encompass team. We're excited to say that Epic, who are the company who are building the Encompass system, built the healthcare in prison system for California, so they're very familiar with the needs of the population. And so we're finding it really progressive to work with them in terms of what we'll be able to pull out. I think in the last few years we've done a lot of work to improve the data we already have and to have good access to information. Some of that is joint a bit with NIF, so we look at self-harm data together. But we also look at we have very robust data that shows the number of people who are transferred, for instance, to a mental health facility, and the fact that that's risen by 58% in the last 2 years. We can demonstrate that despite that rise, we have seen a significant downturn, more than half the waiting time to transfer. So we are improving our data sets all the time. We also have very robust data around our blood-borne virus screening system, our TB screening, and COVID created a new opportunity for data development, and we have had some of the best reporting in Europe around our COVID vaccination programs and our testing. So this is just, we're excited, I think, by the data, that especially the geeks in the team, but there's huge opportunities to share internationally. While we are underfunded and there's lots more we could do, we are doing some things very well within Northern Ireland prison setting, and the things that we do in partnership with our colleagues in the prison service are the things that get us the best results. We have another lovely programme around the menu work that we did within the prisons more recently, working very closely with the kitchens, looking at taking a public health approach, where we have seen a 30% increase in people who are choosing healthy options. And that, it's a very small change that can make a huge difference in terms of the general population and well-being and the impact of public health in the future, which is what we need to be about.
Okay, thank you.
Okay, thank you for that, and nothing geeky about figures at all. You should try being a politician in a PR election and you'll find pure geeks there, but thank you for that. And maybe, Chair, if I could just ask a second question. It's in relation to the issue of, and I think it's maybe been just touched on already, but it's the number of people that would be waiting for an assessment but they're then released and they don't get the assessment, and then just the impact that lack of assessment would have potentially on them reoffending and making it back in again into the prison system. So just what measures have been taken to try and ensure, I think there was 187 were the cases, there was 23 were seen within the 48-hour period, 120 were within the 10-day regional target, but there were 33 that didn't get seen at all. So maybe what's causing that delay? Is that a resource issue, and what's been done to address that?
Yeah. So the bottom line is that it is a resource issue in terms of the availability of staff to do those assessments from a mental health point of view. And we have a prioritisation system. Now, that is to say they may be waiting a very specific assessment. They will have seen lots of staff. Those are things important, that people in prison have really good access to allied health professions. We have OT, physios, speech and language therapists, now psychologists, GPs, psychiatrists, CBT practitioners. So while they may have had one outstanding assessment, it's likely that they will have seen people. We have worked very closely with our GP colleagues in the community to develop a transition pathway. So all people who are released from prison, we write to their GPs and we outline anything that was outstanding so that they can make onward referrals. Or if it is a mental health assessment, there's now a regional protocol that we developed in collaboration with the board, which ensures that people who are on a waiting list for a mental health assessment in prison do not have to go on to a new waiting list in the community, that their care is transferred. So if they're already open, they're automatically transferred, and if they're on a waiting list, they're transferred to the same area. And we also now upload a lot of this information onto the Northern Ireland Electronic Care Record, so that if somebody changes GP or if it comes in front of a practitioner who isn't aware of their previous history, they can find that information on their electronic care record. But that is something that we are continually working on to improve in terms of transition, because it is key to be able to transfer that information out. We also tell our colleagues in the community that we are a 24-hour service, so the healthcare teams in the community can contact Healthcare in Prison 24/7 to ask for updated information, and that we can share it under our data sharing agreements.
Okay, thank you.
That's great. Thank you very much, sir. Thank you.
Thank you, Colin. I'm going to Paula, but I will also check with Rachel Woods. Rachel, we think we've seen your hand raised there, so after Paula, I'll just check with you if you wish to ask a question. Yeah, your hand's back up. So thank you. Paula, go ahead, please.
Okay, thank you, Chair, and thank you, panel, for the update today. Very interesting. I suppose coming at this stage, my questions are a little more specific, and the first one's in relation to the screening when the prisoners arrive, and I'm just wondering, to what degree you actually screen for gender dysphoria, because if patients are not getting the treatment they need in relation to that, then that can also cause mental distress. Second question is in relation to the rise in eating disorders as a manifestation of mental ill health. I'm just wondering how prisoners with eating disorders are supported. Thirdly, in terms of communication with their parents and loved ones, it's just conscious with the pandemic, for example, communication was probably stifled a bit. I'm just wondering how you're facilitating that so that people can get reassurance when they're having an episode of mental ill health from their loved ones. Thank you.
Thank you, Paula. So, screening, first of all, who'll pick that up?
Chair, we can take those from the Trust.
Yep, thank you.
So, as I said, anyone who comes in is assessed on arrival. There's a number of different assessments that take place within the first 3 or 4 days. So any known diagnoses, we will link with the teams that they're currently working with. So gender dysphoria or eating disorders are very specific. We actually have extremely low numbers of people with those diagnoses. In fact, currently we don't have anybody with those diagnoses, which is interesting in of itself, given the increase, and especially we would expect to see that in our female population, but it is not something we see often in the prison setting. So we do not have a specific service in the prison for those issues. However, as part of the wider South Eastern Trust Adult Services Directorate, we can access the specialists as required, and they can either come in or our patients are able to be transported out for external appointments, and we do that again in collaboration with the prison service to ensure people have.
Okay, sorry, just before you go on, you'll know there's a waiting list to actually get, say, a consultant to be diagnosed with gender dysphoria, so you may well have prisoners presenting who haven't actually got the diagnosis. So I'm just wondering how you would be picking up where they haven't had a formal sign-off, for example, from a consultant.
Yes, well, I mean, if they were on a waiting list, we would see that as an immediate need. So yes, for sure, we would. But as I say, it's interesting that we have had very small numbers of people who identify, as a different gender, and that they are managed. The Northern Prison Services have a policy of where they're located, and they have a policy of how they're managed, and as do we, in terms of access to services. As I say, we have a wide range of therapies on site to support their needs. So I think we would link with the team that they're currently work with and link with the specialists to get advice.
Okay, and in relation to the eating disorders then, before I leave the Trust?
I think they covered that, Chair. I think the other questions really in relation to communication with the outside world, effectively.
Yeah, so that's probably back to maybe Ronnie, is it?
Yeah, Chair, I'm happy to take that. I mean, we have a family engagement strategy in place at the moment, and that has worked extremely well for us during the past 2 years as we've managed and tackled the challenges of COVID. I think it's worth saying, in terms of communication with the family, throughout the past 2 years, we've had an extensive virtual visits programme in place that has allowed all of those in our care to keep and maintain that contact with the family. I would also want to pay tribute to the work of the voluntary and community sector within our prisons who do an outstanding job on behalf of ourselves in terms of keeping contact with prisoners. And NACRO is one organisation. There are many others that have been mentioned today. And then finally to say that we have our prison chaplains who again do outstanding work in keeping that connectivity between prisoners and families, and they work alongside our family liaison officers in the prisons as well to ensure that that communication flow is as good as it possibly can be.
Thank you, panel. Thank you, Chair.
Thank you, Paula, and I'll go then to Rachel. Go ahead, Rachel, please.
Thank you, Chair, and thank you to everybody for coming today, for having this meeting, and also for the report as well. A number of questions have already been asked, but I wanted to pick up on some of the stuff that was in the report. Page 14 is talking about the 2021 health needs assessment. It was underway, but it wasn't complete at the time of the field work. I'm just wondering if I could find out if this work has been completed, and is that data going to be made available?
Sure, I would be happy to come in on that point.
Go ahead, Paul, thank you.
Yeah, thank you very much for the question. And no, the work has not been completed. The work has been outstanding now over the period of the pandemic. We set up a task and finish group specifically to build on the previous needs assessment, which was commissioned and completed back in 2016-17, I think. Unfortunately, due to the pandemic, the leads who were associated with that particular task in the Public Health Agency were redeployed to other tasks as part of the work that the Public Health Agency have been taking forward over the last 2 years. It's not to say that no work has been done. I do actually have a draft copy of the needs assessment, which needs now to be reviewed by our planning team. So as soon as we can get that group back together again, we will be prioritising the needs assessment process. You're quite right to pick up on the issue about needs assessment, because the words needs assessment are peppered right across the report. And I suppose we welcome the reference to that from the RQIA, because we absolutely acknowledge that we need to complete that work. Once we've got that needs assessment completed, I'd be very happy to share and have a further conversation with anybody who's interested in making any particular comments on it. In terms of taking it forward and completing it, needs assessment is a rolling process. This one that we're looking at the moment is focused on mental health issues. We need to carry out needs assessment in terms of the totality of issues that are within the prison system, and we shall be doing that as well, and that'll be a rolling programme, hopefully going forward.
Thank you. Just wondering if is there a target timescale for that work to be done? Obviously, this is the 2021 needs assessment. I appreciate we're going into 2022. So, just wondering, would it be this year that work is to be finished?
I would absolutely. Again, we need to reconvene with the leads of that task and finish group whenever they're back with us from their other duties. But absolutely, I wouldn't like to think that this process is going to stretch into another year. In fact, we'd probably be looking to complete it in this calendar year.
Thank you very much. In terms of and I'm going to pick up on the discussion and the reference that has been made to the CSUs. Page 4 of the report says, and I quote, "Some acutely mentally unwell people are being looked after within the CSUs rather than receiving appropriate inpatient treatment." I'm just wondering if those people have been identified, and why are they in the CSUs if they are, mentally unwell, as the report refers to them? And is there any indication that those people are still within the CSUs?
We don't have anybody, Rachel, in the CSUs at the moment that are waiting a transfer to, for example, an outside hospital. Very often people find themselves in the CSUs because of their behaviours. And as I think I've said to the Justice Committee previously, they find themselves there because we don't have anywhere else where we can manage the situation and manage them. And I think this is referring to people who were waiting on transfer orders to outside hospital, for example, but we don't have any of those at the moment.
Thank you, Ronnie. And this brings that to the next couple of points, and one just for yourself, because I think you'd referred to it, a 4 million a shortfall. Could you explain? Sorry, apologies if I missed it, Ronnie. You'd said shortfall of 4 million. Is that for this financial year, and is that in relation just to prison healthcare? And then finally, and I suppose that would be for everybody, is there a recognised need now, stemming from this report and others, that we need to have a secure mental health ward in Northern Ireland?
The 4 million I was referring to is the figure that's referred to in the report. When RQIA did their assessment and they reached the conclusion that prison healthcare was significantly underfunded, they calculate that it was around 4 million per annum. So I was simply drawing the committee's attention to what the RQIA have said.
And we'll pick up the other point, Chair. Margaret.
Yep, thank you, Margaret.
Yeah, just in relation to the issue of secure mental health beds, I suppose from a healthcare perspective, we would not be in favour of that being located within the prison footprint. Acute mental health services is a secondary service. Healthcare prison health care is a primary care service. We feel if someone needs transferred to an acute mental health bed, then it's better that they go to a centre of excellence for that, and that is outside of the prison walls, but can be provided securely. And we think that that's the best option for individuals to go into hospital for their treatment, and then if required, return to the prison then for the duration they're meant to be there. But we feel that that gives better outcomes for individuals because they get a chance to receive treatment from those with the best skill set to deal with their circumstance.
And if I can just add to that, Rachel, just to say, we do feel that what Margaret's outlined is the best model for patients, but also just in terms of the overall big picture here, I don't think it would even be anywhere near affordable to provide, a 24/7, 365-day-a-year inpatient acute mental health ward within a prison, because the priorities for us are the recommendations within this report. We are absolutely committed and support the Health and Social Care Board in terms of, there's so many services here that need to be commissioned, and they would really take the priority if we're going to get upstream. We really want to focus on prevention and early intervention, really helping people with their mental health well-being and recovery. And that's really if we have to prioritise our resources, it would be in addressing the recommendations. We would be concerned about the level of unmet need and the fact that there's £4 million per annum of further investment needed, and that I think will be very challenging. But suffice to say, the Trust, we will deliver all services that are commissioned by the Health and Social Care Board, absolutely. And one of the very positive things I think is absolutely recognising the really strong, robust partnerships that the Health Service have got with our colleagues from the Northern Ireland Prison Service, and that is the only way to deliver these services. But we want to think to the medium to long term now, and recognising the figures that we've received, with the 25% higher levels of mental health within Northern Ireland prison population, that has to be reflected then in how we're going to commission and fund services going forward. But finally, just to say, as I said positively, I've been involved, I suppose, right from the start since 2008, and we have been growing our skills and our expertise and really our commitment to prison healthcare services. I've been out myself just recently in 2 of our prisons meeting with the healthcare teams, and things are really moving forward, which is excellent. And that 4 or 5 years ago, even if there had been the funding there to recruit posts, there wasn't really the high level of interest. There were a lot of vacancies, so it was concerning from a risk and a safety and a governance point of view. But now our teams are full, and we have been able to promote prison healthcare as a specialty of healthcare in its own right. And that genuinely is just down. We'll have to take the opportunity just to say the commitment from Rachel and Margaret, to this sector is absolutely fantastic. So I would want to assure the entire meeting of that. But it is really, really important, because if we want to address these recommendations, but I really do appreciate how challenging the funding of this is going to be, and I think that will be a matter for the Assembly and the Executive to prioritise.
Okay, thank you.
Chair, I just wondered if I might comment.
Yes, briefly, please.
Yeah, I mean, I think it is important when we're talking about resources and we're talking about CSUs to look at page 41 of the report, because page 41 makes it quite clear that an underlying factor impacting on the use of CSUs is the lack of suitable alternative, primarily the lack of regional forensic secure beds, compounded by a shortage of acute mental health beds across the region. And I do feel I have to make the point to the committees, until this issue is addressed, the Northern Ireland Prison Service will continue, along with our colleagues in the South Eastern Trust, to be left with people within the prison system who shouldn't be there and who should be in outside hospital. So the resource point, I think, is a really crucial one. And we do need to do better. I think this is what the report is clearly saying to us, because it isn't right that the South Eastern Trust and the Prison Service are left to deal with a situation that we frankly are not in a position to deal with, and often CSU is the only alternative that's left available to us, and I fully accept, that's not the right alternative or the best alternative.
Yeah. Okay, thank you, Ronnie. And I would have liked to have asked a follow-up question in relation to the ongoing and further engagement with support groups and organisations, but I'll maybe ask the clerk to forward that in writing, and maybe we can get that back in writing. But for now, I want to thank each and every one of you very sincerely for coming along to our concurrent committee today, for presenting the report and the verbal presentations that you made, and for addressing committee members' questions. And I want to wish each and every one of you all the very best in the time ahead in what is very challenging work, a very important work, and working with a very vulnerable cohort of people in our communities. So I thank you for that, and thank you for attending. Okay, members. Any comments members wish to make in relation to the briefing that we have taken from the panels?
I suppose, Chair, just will be, I suppose, in our respective committees, I think we need to just maybe continue seeing what are the issues that we can continue to. I think the points that Rachel made in relation to some of the issues, I think we'll have to follow up with the department, and I think likewise yourselves, and I think it'll be useful at some stage, probably not in this mandate now, but when there's a new mandate, that this issue is revisited again by joint committees, because I think this is a good way of doing it, I think, because there's an overlap. So at some stage it would be useful to set a marker down for us to review this maybe in a number of months after the new mandate, if there is such a thing, is in place.
Okay, thank you, Mervyn. And yeah, there's a number of issues there to be followed up on. Clerk, are you content that you have enough clarity on those? Yep. Yeah. Okay, members, so are members content that the draft minutes of this meeting will be approved by the chairperson of myself as Health Committee and the chairperson of the Justice Committee, and once agreed would be published in the normal way? Right. Members content? Thank you.
Great.
And members, there are no further meetings of the concurrent committee scheduled, but as Mervyn has just indicated there, if members are content, then maybe a further meeting to assess progress on the issue could be considered between the two chairpersons, and we could discuss that and make arrangements, or the two chairpersons can make arrangements in an incoming mandate to continue to keep this under review. Members content with that? Right. Okay, so members, thank you for your attendance and contribution at this concurrent meeting, and I wish you all well.
Thank you, Chair.
Programme signed.